My name is Peter Hartung. I'm a neurologist from Düsseldorf, Germany.
My name is Marcus D'Souza. I'm a neurologist from Basel.
So maybe Marcus could very briefly start, and then I take over, and then we go to the presentations.
So what is actually digital phenotyping? Basically, it refers to a moment-by-moment quantification of human condition, measured by digital devices. It's a very recent scientific branch, not more than 10 years old, but of course now exponentially starting into development of no barriers at the moment.
Well, we had a wonderful first session that outlined, if you like, the principles of this digital technologies, ePROMs, and now we'll listen to case studies that showcase the potential first results, perspectives, but also challenges of undertaking these endeavors. And it's my pleasure to reintroduce Professor Pia Amato from the University of Florence, who will talk about the use of digital cognitive prompts in developmental age as early marker of disease in the adult. Pia, please.
Thank you once, Peter, and hi, everybody. It's my pleasure to share with you just some thoughts about the use of digital prompts, and especially, but possibly not exclusively, cognitive prompts in the developmental age as an early indicator of health outcomes and disease outcome later on in adulthood. These are my disclosures, and first of all, why digital prompts in pediatric onset multiple sclerosis? Well, they allow timely detection of symptom changes, subtle changes, and so early addressing these changes. They can enhance patient engagement, and in fact, we know that adolescents are typically comfortable with the use of digital tools, which may render it easier for them to report reliably their symptoms, their challenges, their well-being. Importantly, they can reduce the need for in-person visits at the hospital, minimizing the impact on school attendance and social activities. They are in line with a holistic view of well-being and providing real-time data. They foster data-driven, personalized care. They can improve the involvement of family members in monitoring and supporting the patient journey. And above all, they can provide probably predictive insights into adult life and help us to identify those individuals who are at higher risk of having worse disease outcome or progression. So we must be aware that there are a number of challenges with the use of pediatric prompts. We should consider several factors such as the subject cognitive ability, the willingness to cooperate, the availability of well-validated instruments in different classes of age, and also the opportunity to choose between patient-reported and observer-reported outcomes. So observer-reported outcomes are different from proxy-reported outcome. In fact, the observer that here is typically a parent should report signs, events, behavior that are really observable and do not include the subjective and personal judgment or interpretation. On the other hand, proxy-reported outcome may include assessment of aspects that cannot be reliably and entirely observed, such as, for instance, fatigue, pain, quality of life. And with this, proxies reported outcome, we often see a disagreement between self-report and proxy report that is called cross-informant variance. So the recommendation provided by ISPOR are to use PROMs whenever possible in pediatric studies as well as in adult studies. And in addition, in pediatric studies, also the input coming from parents or caregivers using observer-reported outcomes are important to gather the unique perspective of both the patient and the family member, separate from the perspective of the clinician, whereas the use of proxy-reported outcomes is discouraged unless it is the only option to obtain patient insight. And these are the recommendations based on the age of the subject. You can observe that between 8 and 11 years, there is improved reliability and validity of self-report, and starting with 12 years on, self-report is typically preferred. So focusing on cognition, we heard how important is cognition for the patient in the first session. We have to take into account a few peculiar considerations in the pediatric age. In fact, disease occurs during ongoing brain growth, myelination, maturation of brain networks that can be involved in cognition, then during the learning curve of the subject, and during years that are critically important in the scholastic career of the subject. We have also to consider that the disease in these young patients is highly inflammatory and active, both clinically and radiologically. But on the other hand, it is deemed that brain plasticity and capability of recovery may be more efficient in this age and might better mitigate against pathological changes. Well, this is a kind of recap of what we know about cognition in the developmental age. Cognitive difficulties are documented in nearly 25–30% of the pediatric patients and can be very early featured. Pediatric patients tend to accumulate physical disability much more slowly than adult patients. On average, it takes 10 years longer, and therefore they can exhibit cognitive difficulties that are dissociated and are out of proportion to their physical disability measured on the EDSS. The neuropsychological profile is consistent with that we know in adults, but can also involve, in a few cases, language and general intelligence. There is negative impact on everyday functioning, behavior, school performance, and indeed, reduced school performance can be an indicator of cognitive difficulties. There is a high risk of psychiatric comorbidity. The onset of the disease in the pediatric age may be a risk factor for cognitive difficulties in adulthood, and it may be also a risk factor for poorer attainment in work and social activities in the adult life, and I will briefly discuss the last 2 points. This is an Italian study where we compared the cognitive performance of patients with a history of pediatric onset with that of patients with a classical adult onset disease, and you can observe that in all the classes of age, patients with a pediatric onset, the blue bars compared to adult onset patients, the orange bars exhibited higher frequency of cognitive difficulties, and we suggested that the onset of the disease during the pediatric age may pose the subject at higher risk of presenting cognitive problems later on in adulthood. And this is also the conclusion from this larger and registry-based study in Sweden involving more than 5,700 people with MS, 300 with pediatric onset disease. You can observe comparing the two curves regarding the single-digit modality test that not at the beginning, but during the follow-up, those with the pediatric onset tend to exhibit reduced information processing efficiency performing the test. We have also to be aware of the potential psychosocial consequences in adulthood. This is our 12-year follow-up study where we found that those with cognitive impairment had a poorer social and work attainment later on in adulthood. And these are two registry-based studies. On the left, a Swedish study showing that having pediatric onset disease is associated with less educational achievement, lower earnings, and greater use of disability benefits. On the right, a Danish study where children with MS were compared not only with healthy children, but also with children with other non-neurological disease, for instance, inflammatory bowel disease. The school performance seems to be comparable, but importantly, less children with MS attended high school, so suggesting, again, less educational achievements. And importantly, they had increased psychiatric comorbidity with an hazard ratio of 3.4 regarding depression, anxiety, and bipolar disorder. These are the main assessment tools used in the literature for cognition in pediatric MS, skipping the lengthy battery and focusing on the brief ones. The single-digit modalities test, we have a computer-based version validated in the pediatric population. Then we have the BICAMs and this computer-based battery, the brief cog state battery, that is also validated in the pediatric patients. This is very briefly the validation study of the computer version of the SMD in Canada, showing good performance and acceptability. And this is the US validation for the cog state battery against the BICAMs. Very briefly, if I have 1 minute, can I? Quality of life, we have the most well-validated and used scale is this PEDSQL scale that has been used also in this paradigm trial on fingerling mode. It's a questionnaire. There is a version for self-report and a questionnaire for parent report. And I think it could be easily adapted into a digital tool. Similarly, the most well-validated fatigue scale is this PEDSQL multidimensional fatigue scale, well-validated and again provides an interview for both the patient and the parents. And we have used it in our Italian study showing some disagreement between fatigue self-report in 14% of the children and adolescents and parent report of 39%. But anyway, as in adults, fatigue was associated with depression and cognitive problems. So just one key point, we hypothesized that using cognitive prompts could offer predictive insights into adulthood and could help us to identify subjects who are at higher risk of poor outcomes in adulthood later on in their life. Thank you for your attention.
Thank you very much, Maria, for this excellent talk. I would like now to introduce Agne Kazlauskaite. She is a member of the Working Group 3, a lead of medical science in Roche, and she has a PhD in biochemistry and in molecular biology. Her title of this presentation would be Learnings from Longitudinal Data Analysis in Floodlight Studies.
Thank you very much for organizing for this opportunity to present the data today, and thank you all for your time. These are my disclosures. Digital endpoints offer unique transformational benefits to clinical trials by utilizing data collected through health devices such as wearable devices, smartphones, or sensors in high frequency and in real time. By potentially utilizing such endpoints in clinical trials, we stand to have faster, more cost-effective, and more patient-centric trials that fundamentally would lead to faster and more accelerated development of novel therapies. However, for such endpoints to be employed, we have to go through a robust understanding of the performance characteristics of such tests, including technical validity, clinical validity, and sensitivity to longitudinal change. In order to establish these qualities, we need to employ digital devices in clinical setting. Consonance is one such study where Floodlight has been deployed. Consonance is a phase 3B single-arm open-label study where clinical assessments such as EDSS and 25-foot walk test has been collected during regular clinical visits every 6 months. In addition, Floodlight has been deployed through a provisioned Samsung device, and due to the time of the start of the study in 2019, no notifications or reminders were available in the app itself. Patients were asked to collect and complete the tests on a daily basis, with the exception of cognitive tests due to practice and learning effects. Adherence was not enforced, therefore, consonance serves as a study in adherence itself. I will be presenting data from a sub-cohort of the overall population of around 368 patients, around 50% of which were female, almost one-to-one ratio of secondary and primary progressive MS patients, average age of 48.5, and a mean EDSS score at baseline of 5. So these are patients that had already accrued disability by the time of entering the study. Now, gait is one of the most commonly affected functional domains for individuals living with MS, and therefore I will focus my talk on gait today. And disturbances of gait express themselves by both reduction in gait speed, imbalanced gait patterns, difference in step length, as well as overall difficulty maintaining balance, all of which have a strong effect on the overall patient's quality of life. Now, 25-foot walk test that is commonly deployed in a clinical trial setting only gives us information about gait speed, and it does so infrequently depending on the schedule of assessment. Digital tools, however, give us further insight by providing us a number of variables, including spatial variables such as step length, overall distance walked, and number of steps, the latter of the two also giving us a sense of endurance, temporal variables such as step duration, and spatiotemporal variables such as step velocity. Now, while I will be focusing on clinical validation cross-sectionally and longitudinally in this presentation today, I wanted to note that analytical validity has been proven outside of the study using state-of-the-art motion capture systems and treadmill in a lab, showing near-perfect performance overall. So, to consider employing a digital endpoint in a clinical trial, one must ask whether what we're capturing with it is clinically relevant. To that effect, the very first thing we wanted to do is to check the associations between digital step velocity and known clinical metrics. So we checked it with 25-foot walking speed, MSWS-12, which is a patient-reported outcome, EDSS step, and ambulation. As evident by Spearman rank correlations, we see moderate to the PRO MSWS S12, or strong associations with the rest of the clinical outcomes. In addition, we wanted to see whether this feature could also distinguish the well-known groups. To that effect, we took the population and we divided that into EDSS subgroups of patients with EDSS 1.5 to 3.5, 4 to 5.5, 6 to 6.5. As you can see on the right side of this panel, digital gait speed shows excellent discrimination that is highly significant across the different groups. Once we have established that gait speed does measure clinically relevant metrics, we wanted to see how it performs over time and whether it's sensitive to change. To that effect, we looked at the overall population and compared the performance on the 25-foot walk test speed and the digital step velocity. And we see that overall, the population shows comparable trends with around 10% decline over the course of 3 years. Furthermore, to understand it better, we tested whether the features can distinguish between patients that will have had an EDSS progression event plotted in orange versus those that did not, plotted in blue. As you can see, both features do distinguish between these patient populations. But what I would like to call out is that the digital step velocity shows a trend downward from week 24 onwards, and I will speak to that a little bit more in the next slide. Now, I mentioned before that digital tools provide us ability to see more than just speed. When we look at the other features mentioned before, we see similar performance overall. But I would like to ask you to focus your attention to the two rightmost panels with the total distance walked and number of steps that are also measures of endurance. What you see here is the non-progressive group that is depicted in blue shows disability progression starting at the baseline. This suggests that digital tools can capture subclinical changes in patients that are considered clinically stable. Now, what does that all look like for an individual patient? So this is a primary progressive MS patient with a baseline EDSS score of 3.5. You can see that this patient specifically had a very excellent adherence, depicted in blue dots over the course of 4 years. And it's also very evident that this patient had a dramatic and severe disability event at the very initiation on the study that is evidenced by decrease in step velocity, step length, a number of steps taken, increase in step duration, all of which combined leads to a massive decrease in the distance walked. We also see that the patient, for reasons that are not explainable by the digital metrics themselves, had a lack of adherence at around 2.5-year mark. When we add clinical data for this patient and look at the performance on 25-foot walk test, we do see that this patient also has a progression event on 25-foot walk test at week 24, depicted by the first red dot. This progression event fundamentally led to instability of gait that leads to a number of falls, and the lack of adherence or lack of data itself is due to hospitalization due to NAE. And this is one of the cases where lack of information is information in its own right. So, hopefully throughout the course of my presentation, I have managed to show you that digital tools do have or do display the characteristics that require to qualify them as endpoints in clinical trials, both by being clinically valid and be able to capture changes over time. Not only that, they are able to distinguish between patients that are considered clinically stable or not based on EDSS. And in addition, they might offer us potential to detect change earlier and show changes in patients that are considered clinically stable. And I would like to end this by saying that I believe that it's in the intersection of the digital and clinical outcomes together that we stand to learn the most about both the individual patients and the progression overall. Thank you very much for your time, and thank you for the opportunity to present this.
Thank you very much, Dr. Kazlauskaite. It's now my pleasure to introduce Gavin Britton, who's a clinical lecturer in neurology at the University of Sheffield. His main research interests are digital monitoring of MS and the use of autologous hematopoietic stem cell transplantation. And he will talk about Mobilize D, lessons learned from passive mobility monitoring using a wearable sensor. Gavin, please.
So thank you. I'd like to thank the organisers for the invitation to talk. And the work in this talk is part of the Mobilize project, like we've said. This was an EU-funded consortium, but I don't have any other disclosures to make. There's been a really good backstory provided by the previous speaker, by Letizia, by Angela to all of this. So I'll try and keep this brief. But we know there's this big growth in digital health, e-health tools across neurosciences, not just MS. But within MS, the primary uses currently in clinical trials are motor function tracking and tracking of disease symptoms. Clearly, motor function tracking is not just mobility or gait, but that's what Mobilized was focusing on. So mobility itself is quite a broad definition, and it's the ability and performance of a person to move. But for this presentation and for Mobilized, it was focusing on the ability to do that without a vehicle, so ambulant participants. Mobility impairment is clearly complex, it's multifactorial, it involves changes in muscle weakness, ataxia, sensory dysfunction, all on the quality of movement, but also environmental factors, and there's a real bidirectional impact there. Historically, MS results in mobility impairment in almost 9 in 10 patients during their lifetime, with 3/4 of patients needing a walking aid during their disease course. Hopefully those figures would drop. And as we've heard, it correlates with social outcomes. It's an important patient-perceived disability, and it correlates with declining mobility correlates with unemployment, loss of income, rising healthcare costs, and reduced quality of life. We've heard a little bit about how to measure mobility, and the way we've viewed these within the consortium is all appropriate outcome measures that look at, they're all appropriate outcome measures, I should say, and some look at mobility performance. So these are largely patient-reported outcome measures. These require a patient to reflect within themselves and average out their symptom burden, say, over the last 2 weeks, like the 12-item MS walking scale. That does introduce a slight recall bias. We can look at mobility capacity, which is what a patient can do under direct observation, or a snapshot, so a 25-foot walk time test or 6-minute walk test. We've heard about 2-minute walk test as well. Most of these are conducted in the clinic, clearly not all, but that mandates patients to need to come to clinical centres when we do that in hospitals. What we're wanting to introduce is this aspect of mobility performance, which is what a patient does in their own environment consistently, and that's attained with wearables, and that's this real-world walking or a patient's lived experience. We're interested in this real-world walking with the hypothesis that it can capture disease fluctuations, environmental factors, and this mobility performance. And it produces what we've termed as digital mobility outcomes. So these span several domains that I'll cover in a bit more detail later, but look at various aspects of mobility. We know from our systematic review from a few years ago that real-world walking has been assessed previously, and we've heard about that already. But the vast majority of studies just focus on gait speed, usually with a stopwatch during short walks or daily step count. And these approaches have their own potential flaws, and they examine just one aspect of mobility. Within the Mobilize consortium, we aim to complete technical and clinical validation of digital mobility outcomes across 4 different disease cohorts. Obviously, we're only concentrating on MS here. And for the MS clinical validation study, we undertook clinical assessments, supervised walking tests, and assessments of physical and cognitive function. And these were then followed by 7 days of unsupervised, so real-world walking, where a patient wore a wearable, so an inertial measurement unit, which are what's shown in A and C. So A was affixed with an elastic band around the waist, and that could go under the clothes. It's just shown as on top of the clothes here. And then the sensor in C was affixed with a dressing to the lumbar spine, again under the clothes, and the one in C is water resistant, so they could shower in it. After 7 days of monitoring, a patient would either return it to the clinical centre or post it directly, so there was no need for an internet connection or any other active involvement from the patient other than to get it back to the centre with a prepaid service. We used a device-agnostic approach, so we could interchange these two sensors, and it's the analysis pipeline that's been validated rather than the devices themselves, which means we can swap in other devices in future, providing they meet a minimum technical parameters. And it's the early signals from the baseline data from the MS clinical validation study that I'll show you. And the inclusion criteria broadly was really just any MS patients with an EDSS between 3 and 6.5, so that is mild MS to obviously requiring 2 aids to ambulate at least 5 meters. We recruited 602 patients from 4 centres across Europe, as shown on the map on the left-hand side, and they were moderately disabled according to their median EDSS of 5. Just over half of our patients had relapsing remitting MS according to their clinician-derived phenotype, and the rest had progressive MS. Most of them had secondary progressive MS in that subtype. We considered valid data within the pipeline to be a minimum wear time of at least 12 hours per day for at least any of the 3 days from the 7 total days. And there was no requirement for a minimum weekend or midweek number of days at all. And the ease of this passive monitoring approach, like we've heard from Angela, led to over 92% of patients having usable data at baseline. And there were no significant effects on the demographics or clinical parameters in those that had usable data versus those that didn't. So we didn't unfairly discriminate and exclude patients with, say, advanced MS, as long as they could ambulate clearly. The digital mobility outcome measures that we've included in the initial round of our analysis are the ones shown on screen, and we considered bouts of over 10 seconds to be those that would be analysed, and that was just to reduce noise from really short bouts. And we've taken a slightly different approach to Floodlight and splitting the DMOs into walking activity, so those that cover sort of volumes like step count and pattern, and to other DMOs that look at gait, so pace, rhythm and variability. We can look at these DMOs either per day, with a mean per day at the bout level, or over a mean of over the 7 days. And there's also lots of other aggregated or novel metrics that we could draw from this raw data that we've got. So we've seen that within the Duchenne muscular dystrophy, they've had the 95th centile of stride velocity pass through regulation, and you could look at that with this data if we wanted to. You could also aggregate walking bouts and do other interesting things with the data. But this is the minimum DMOs that we've got at the moment. As we expected, almost all of the 24 DMOs correlate well with constructs of disease severity measured by EDSS, patient-reported outcome measures, so the PDDS and the 12-item MS walking scale, and also with measures of mobility capacity constructs, so the time 25-foot walk and the 6-minute walk distance. There's 2 example correlation figures just showing between group differences at the top with EDSS. But in essence, as disease severity increases, patients' real-world walking bout parameters, gait parameters, consistently deteriorate. In lieu of us having the longitudinal data and just having the baseline data, we had a look at what happened in these clinician-derived phenotypes of progressive MS, so the primary and secondary, and patients with relapsing remitting MS. And almost all of the DMOs show between subtype differences, but clearly a big contributing factor is EDSS there. So when we control for gender, age, height, and EDSS, which I acknowledge isn't perfect, but MS patients' gait is different between subtypes. So these are patients who's had their EDSS controlled for, and in essence, patients with progressive MS walk less at a slower speed, a lower cadence, and have less within bout-to-bout variability of both walking speed and cadence. Probably the most important slide, and this goes back to Angela's really nice presentation, is about the patient thoughts on this. And some of our active monitoring studies in neuroscience and across other disciplines have had difficulty with compliance longitudinally. And within Mobilize, we've had really good adherence throughout the 2-year study with consistently high mean wear time throughout the study. So we've had 6.7 days from 7 days. So patients didn't take it off halfway through the week. They didn't forget to put it back on if they'd taken it off overnight. And we had very minimal withdrawals, you can see in the bottom left chart, from issues with the sensor. The table on the right shows the adherence or the acceptance from patients with the sensors, and largely it was found to be comfortable, it was easy to put on, It was easy for carers to put on if needed. And in the bottom red square, we can see that upwards of 95% of patients felt being monitored like this was acceptable, and almost 80% of patients were willing to wear the device in clinical care now. So in conclusion, it's a valid construct, measuring gait in this manner. There are some subtle aspects of gait that are different between subtypes, but really we need the longitudinal data to look for disease fluctuation, for PIRA, for progression there. It's just a subtle indication at the moment. My own thoughts are that this passive monitoring approach is what's led to high quality gait data with really good compliance and good acceptance from patients. And I think it would improve inclusivity in clinical care and trials, but there are clearly challenges ahead. We need to get regulatory qualification, we need to use it as a secondary endpoint in a trial, and we need to think about the visualization both for patients and clinicians, because patients want to hear about their results, and I don't think we could even discuss this with patients or clinicians in the clinic in the manner that I presented it. Lastly, I'd just like to acknowledge the rest of the consortium and all the PIs and co-Is listed on screen of the MS arms.
It's an honor. Oh, sorry, it doesn't work. Thank you very much for this excellent talk about Mobilize D, Gavin. And now it's an honor to introduce Professor Jeremy Hobbit from Plymouth University Hospital. And I'm very keen about his presentation on the how and why forensic analysis of the symptom screen data explains the smoldering associated worsening index study. The floor is yours, sir.
Thank you very much for the invite. This is relevant to digital work because most PROs will be digitally available, and the theme of this is really about how we can ensure that the measurements that or the numbers that they generate are accurate measurements. So what I'm going to do is present to you the results of a forensic analysis of some symptom screen data, and then segue the results of that into how it justifies the Sanofi-funded SOAR index study. And I hope in doing so that I will convince the PROMS initiative and its stakeholders of some essential programs of work in measurement that I think are really valuable. So the symptom screen study, these are my co-authors. It's actually here as a poster on number 96 if people want some more detail, and thanks to Roche for funding the work. So for those who are unfamiliar, symptom screen is a 12-item questionnaire. It was developed as a routine assessment method for use in clinical practice to fit on one page to cover the most important items of MS in terms of symptoms, and it uses a 7-level response category format for precision of assessment. Now, after it was developed in 2016, there was interest in it from a conceptual perspective as whether it would be a useful outcome measure for clinical trials, and that different role brings different requirements. It's also attracted the attention of the PROMS initiative because it may be a vehicle for encouraging more use of PROMS in clinical practice, which, as we know from the literature review, is rare. We had a very large data set that you can see here of over 3,000 people, and by forensic analysis, I mean testing criteria against stringent requirements for measurement from these types of data, identifying discrepancies, diagnosing limitations so that measurements can be improved and the measurement values are more valid. Our analytic paradigm was rash measurement theory, and I'm just going to give you 2 major results that show you about how they affect the validity of scores and the interpretation of score changes. Now, you're used to numbers being presented in papers, but people rarely show distributions, and the distributions are really important. You never see the reporting of distributions of the persons in relation to the distribution of the instrument, as you can see here, below the distribution of persons. And that tells us that, in fact, 40% of 3,606 people are actually measured poorly in that they're an area of the scale where changes and differences will be underestimated. But more importantly, it shows that a large number of people are seen to have low symptom burden who are participating in trials, and raises questions about whether important symptoms are being missed and therefore the content validity of the instrument. And I think that's also been brought up by Gianpaolo's presentation earlier about the 28 different measurement domains. But when we start looking at the instrument, things start getting interesting. And what we see here is the instrument span is very narrow. And in fact, the vast majority of the instrument span is over half that range, which is surprisingly narrow for 12 clinically diffuse items. And when you get a bunching picture like this, it really is suspicious that the response categories are not working as intended. So the response categories, and the key thing about response categories in PROs and in clinical assessments is they are qualitative descriptors, to which we then hang numbers and we interpret those as measurements. But it's the qualitative descriptors that we're interested in. Now, if you do a detailed analysis of these qualitative descriptors for the items, we start looking at things called thresholds. And the thresholds are the points of transition between the different scores for the individual items. And what they do is they form the notches on the ruler at the bottom. And of course, there will be 72 from this instrument. Now, the most striking thing about this analysis is the almost identical similarity of 12 clinically diffuse items. And this concept of things appearing to be so similar is called a halo effect, and it implies that the response options are not working in the way as intended. And that implies in itself that the numbers generated are not valid estimates of symptom severity. So if we unpick this further, then we can start looking at some of the detail. So here, if you take people who responded moderately, you can look at the probability of their estimates. And what you see essentially is that people choosing the same category are equally likely to have very different symptom severity estimates. And the range in the box on the left-hand side is about 33% of the scale range. If we configure that in a slightly different way, and we look at people with the same estimate and look at their responses, then the probability of responding in different categories from mild through moderate to severe is almost identical. And so what this essentially means is that in the main measurement region of the symptom screen, the categories are ambiguously interpreted by people. They don't discriminate between individuals, they're imprecise, and they're not functioning in the way that they were intended when the instrument was constructed. For those using the instrument, it unfortunately means that the scores are really not valid indicators of symptom severity. So, what we have with the symptom screen is problems with the response categories and problems at the item level. The item level stuff is less important than the response categories here. But the issue of importance is by using this type of approach, the problems are easily solvable. And those solutions lie in appropriate qualitative research and hypothesis testing approaches. And that takes us to the SOAR index study. There's a poster here, number 95. These are my co-authors and part of the steering committee, and the work is funded by Sanofi. So the aim of this study is to develop an index for assessment and measurement, and the study has literally been started this month. So how do the two link together? Well, what the symptom screen analysis tells us is the need for high-quality qualitative work, for iterative hypothesis testing approaches, and the use of methods that enable forensic diagnostic analyses. Now, the conceptual clarity, I think, of smouldering MS is reasonably well worked out, but the clinical manifestations remain unclear in certain terms, and that is exactly what is worsening, and more specifically, in exactly what way. So the issue we have is we often use instruments which say they're a bit worse, they're a bit better, mild, moderate, and severe. We need to move beyond those things, because an understanding at that level is required to generate accurate indices, whether they be for diagnosis, assessment, measurement, or prediction. Now, the start point for all this is in-depth qualitative work in people with MS with the condition of importance, which here is smouldering associated worsening, to understand their perspectives and their experiences. But the subtle worsenings in smouldering associated disease that we've heard about in other talks in other different ways across multiple different domains provide substantial challenges to qualitative research. Now, typical qualitative research in healthcare uses a single interview of participants, a single interviewer, and there are no real quality control criteria. So we need to move beyond those sorts of potential limitations when we're dealing with instrumentation that's going to affect diagnoses, treatment paradigms, and whether treatments are effective or not. So how do we get beyond this? Well, multiple interviews of the same people. Longitudinal qualitative research is required to move beyond the single interview and to try and pick up prospective changes over time. So we have 40 people on 4 time points in this pilot study. I think we need to move beyond having single interviewers, because it's actually very difficult for qualitative interviewers to keep on track in these interviews that really drift all over the place. You need a second interviewer in the room to keep the interview on track and to monitor it, and the two ferry between the two of them. To build quality control criteria, we need interview critiquing after they've done, synthesis of the transcripts for the information, identification of missing information so that we can go back to people quickly to pick up on that missing data. And those are things that we've brought into our study. I think we need to move beyond generic response options. And I think the work in the symptom screen demonstrates that those can be very ambiguous and very problematic. And so moving to bespoke response options, both in terms of their number and their qualitative labeling, is an important process. And then the need to be testing our hypotheses, because symptom screen as it stands, it's simply a hypothesis for measurement that has yet to be rigorously tested, except in this study. And we need these sorts of pieces of work. So our study is simple in some ways. We're aiming to develop an index, and in the start point is an assessment and measurement framework. It's 40 people. It's a pilot study at the start. There are 4 time points. They're monthly, which is short, but that builds the rapport and the information, and it's a compromise for the time required for the study. There's the age and the EDSS information and relapses and imaging are here. And the early insights we're getting, which were raised in one of the surveys, that 56% of people found it difficult to articulate their symptoms, it proves that this methodological changes are required. So, to conclude, assessment methods are precursors for, but they're not sufficient for measurement. And we need to move beyond our thinking on this, because using them as measures without formal testing, I think, is damaging our studies. In its current form, symptom screen will produce misleading clinical assessments and measurements, regardless of the alignment because of the response category problems, but they're all solvable and it's relatively straightforward. And I think the work we've done highlights assessment methods and therefore measurement instruments rely on qualitative research and are, in fact, utterly dependent upon it. But the combining of high-quality qualitative research with iterative hypothesis testing, checking approaches is what we need to build our better instruments. And quality control of qualitative work is needed. And we've built several suggestions into the SOAR index study. Final slide. So the recommendations, I think, for the initiative are, I do believe we need coordinated, strategic programs of work. We need to take all our clinical measures, not just the PROs, but the ClinROs, the observation measures, etc., and subject them to forensic diagnostic analyses to determine their strengths and weaknesses so that we can act accordingly to reduce their limitations. We need more head-to-head comparisons, and we presented some work on that last year, and we need some comparisons of methodological approaches. We do have access to the primary source of rash measurement theory. His name's David Andrich. He's based at UWA in Perth. He's 83. We have an opportunity to use his skill set, which is profound, before it's lost, and we should, as a community, we should try and take that opportunity. We need a coordinated plan to train a new generation of people skilled in these forensic analyses and their correct interpretation, because there's a lot of misinformation out there at the moment. And we do need quality control guidelines and improvements for our qualitative methods in terms of measurement instruments to generate high quality estimates. Thank you, and sorry I've overrun.
Thank you very much, Jeremy. It's now my pleasure to introduce Anne Helmy, who steps in for Angela White. She is head of research and access of MS International Federation and will provide us with comments from the engagement coordination team on the case studies we just heard presented. Anne, please.
Thank you very much. And as one of the co-chairs of the engagement coordination team, alongside Helga, who we heard from earlier, it's my pleasure to give a reflection, which is we have prepared together as the ECT team. So I'm very pleased to be speaking on behalf of Angela and Helga and Ainoa and the wider team. So we welcome the insights into the different tools and measures that have been presented during this session. And it's really exciting to see the progress that is being made in this area, and that there is a really thorough investigation of the tools to find out what works well, what doesn't, and why. I think it's also really exciting learning about the potential for detecting change and progression over time, especially through passive monitoring. But it's clear we haven't solved all the challenges yet. The tools that have been described vary in terms of which functional domain they focus on, and as we've heard throughout the meeting so far today, when it comes to symptoms that are most frequently experienced and most impactful for people with MS, this can vary hugely depending on the individual, their age, how long they've had MS, alongside many other factors. Some tools look at only one domain, cognition, mobility, and others aim to capture multiple domains, but it is likely that there is no single tool or measure that will meet the needs of all people with such a heterogeneous condition as MS. But at the same time, we don't want to have to juggle using multiple tools, apps, or measures to capture the symptoms which are most important to us, as well as being clinically valid. We know that adherence to using digital tools and apps is a big challenge, and we need to have the best understanding of the factors that encourage people to keep using a tool or an app. And we certainly hope that the upcoming eHealth survey we heard about earlier will provide these important insights related to this. Whilst not repeating Angela's eloquent speech from session 1, there are some important considerations that we would like to emphasize. Firstly, focus on encouraging and developing passive data collection tools, devices, and methods. Capture data that reflect the entire life of the individual, not just their MS symptoms. Utilize existing technology and leverage AI. So our call to the research community would be this. Please keep on with the research and development of digital tools and digital PROMs, because we know that there is so much potential to improve quality, precision, and timeliness of care for people with MS. But involve people with MS at all stages. There are lots of people with MS across the world who are only too happy to be part of research, sharing our needs, lived experience, and ideas. By working together, we will solve these challenges. Thank you.
Thank you very much to all speakers for their excellent presentations. And now we would like to start with the question and answer session. Do we have our online speakers already on screen? Can you put, yeah. So I think we can start with our first question. Are there any digital prompts already available which measuring the dominant functional domains and at the same time take into account the heterogeneity of different clusters of people with MS. This is now for all of our speakers the question.
Maria Pia?
Honestly, I don't think that we have met this goal to have a digital tool that can transversally be used in different clusters of patients. I would say it's ongoing work.
Any comments on this from the other speakers or the remotely present participants? So that is not the case. So another question would be, which are the advantages in designing, optimizing, using digital tools to record and monitor the most dominant functional domains, in your opinion? Which are the challenges to be overcome? Jeremy? Sorry.
Can you run that by me again? What are the challenges?
Just start with the easy part of it.
So the challenges for digital tools or for PRO instruments? What are the challenges? Well, the challenges for I'll start with the PRO questionnaires that we use. I think one of the primary challenges is to drag people into the reality that the current methods that we use are inadequate for the purposes that we put them at the time point. So, and by that I mean usually the statistical methods and the way we analyze the data. There have been some very valuable methods developed in the 60s that have been around for a long time. They are hard, and people have to work hard to understand their value, but it's been very difficult to convince people that actually improving the quality of your measurements makes your clinical trials more likely to produce truer results and will reduce your sample sizes and your time taken, etc. And it's been really interesting having been in this to see how difficult it has been to convince people. These methods are so profoundly valuable, and yet we're just not taking the opportunities they give us.
Thank you.
A question for Jeremy. Jeremy, I understood from your talk that the MS symptom screen is not a valid to be used in clinical trial because there are great variabilities from one patient to another according to the score for each of the symptoms. But my thinking is that symptom is subjective. So when you use a pain evaluation from 0 to 10, if you discuss with each patient, we give the note 8, you will understand that it's not really what you think about the same severity. But my question is about the use of MS symptom cream in the outpatient clinic for an individual. Do you think that it might be useful for a treating neurologist to have a look on this score before the outpatient clinic in order to have his mind attracted by maybe some of the symptoms in order not to forget to discuss, if useful, these symptoms that might be completely not discussed without any signal on the probe, might be a signal to indicate to the neurologist that he has to discuss with the invisible symptom, fatigue, cognitive difficulty, mood, sleep disorder, and so on.
Simple answer, yep, I think it is valuable. But I think we have to recognize the limitations shown by the analysis and move the instrument forward. So valuable in its current format for guiding some clinical practice. but for measuring and for documenting differences and changes over time, I think there are significant problems which will undermine clinical trials. But the point, Gilles, is these are solvable problems. They're very easily solvable problems, and I think we should try and get on and solve them, because I don't think it will be that difficult, and I think it will be very valuable in the long run.
Thank you. Now, Gary, please.
Yeah, I want to maybe pick up a little bit on what Gilles was bringing up. I think, Jeremy, I agree with your analyses of the goal of getting a single score for the symptom screen. There are good ways of finding out the measurement. But I think one piece that you said could still be true, even though it doesn't work in a combined index. And that is when you have two different scores that are relatively the same, but you have two different symptoms, that they may be accurate for that person. The level of botheration from one symptom can be that level and the same level as someone else, and they're not combinable because they're two different independent, or not necessarily independent, but two different levels of botheration. So as Gilles was pointing out, there are 12 different domains that can be useful for clues to a clinician, which is different than the goal of having a single score that represents the domains of the disease. And I think you're on to finding a better mousetrap for combining these, which I think can be done. But I don't think we should give up the individual scores. That's the value of a single sheet and being able to get that information in a less than 5-minute time period.
Yep, I think it's valuable from that perspective. I think somebody's completion of the symptom screen data is valuable because it tells you an awful lot. But you know, if we're looking at measuring in clinical trial scenarios, if we're looking at whether treatments have an impact on a measurable outcome, then I think we are duty-bound to try and improve those instruments accordingly.
No,
and I think in doing that, I actually
that's
think
the score.
Yeah, but I think I actually think, Gary, that if you do the work required to improve the instrument, you'll get better assessment as well as getting better measurement. I think the two are combined.
I don't disagree.
Thank you. Patrick, please.
Maybe again, concerning the discussion about symptom screen, probably there is a misunderstanding about the goals of the PRO you use in clinic. Of course, I agree with the limitation. You're really an expert to highlight the limitations of different PROs. But in fact, even if you look at the casting Liberto study, for example, evaluating for a long period of time ocrelizumab, even in NIDA patients, in significant proportion of patients, we detect some changes. And if you look in details in such patients, definitely correlated with some true symptoms reported by the patient. So at the individual levels, it's very useful for a clinician. Of course, I understand that for a group, probably a lot of limitation to conclude something. But I think maybe we need to consider some aspects. It's a personalized approach. And I would like to say that in symptom screen, we have some questions related to domains that matter most to patients, you know, mood or cognition, for example. Of course, it's single question, a little bit simplistic view of the domain, of course. But I think as a clinician, I like use this easy tool. It's realistic to use, maybe a very low rate of attrition over time. Of course, it's a matter of to be realistic or not also, you know, maybe a comment.
Yeah, I mean, a lot depends on the context that you want to do something. You know, let's look at the history of this. It was developed as a clinical assessment measure for clinical practice that fitted on one page. But it's now used as a measure. That's a different ballgame. And I think the stakes are very high when you move to clinical trials. And the implications for patients and the implications for prescribing and the implications for drug companies of what happens in clinical trial results mean that we should be duty-bound to maximize our measures. I'm not suggesting that symptom screen doesn't have any value as assessment, but what I think we've tried to show you is that the response categories confuse people. And actually, it's very simple to overcome. With appropriate qualitative work and testing, you change those response categories to bespoke categories in terms of number and qualitative labeling, and you will get better assessment, and you'll also get better measurement. And it seems, I find it hard to think you wouldn't want to do that. If it's really useful to you in clinical practice, why would you not want to do that?
Thank you. Oh, yeah.
Robert?
I'd like to agree with everyone, which I do. I think there's some great points being made there. I do think, and some may recall the variability data that I showed at last year's PROMS plenary using symptom screen, and certainly the difference between different people with MS is quite striking. And I think, to Gilles' point, that's an individual response to symptom screen is a great starting point for a conversation. It's not a substitute for all other assessments, but I think it's a great starting point for a conversation. And secondly it's also a starting point for follow-up. And the follow-up may involve different instruments focused on specific symptoms. And it's more likely that those instruments, in order to see subtle changes that may be not evident, need to be instruments that are developed with the type of forensic evaluation that Jeremy has talked about. So I think we don't, a lot has been said about from clinical trials to clinical care, but they are very different situations. And I think that one of the things that needs to happen is, like Gilles is doing, is to explore the value of that simple instrument, because we need something to begin to explore ways to overcome the cultural, technical, and financial barriers that we have, that I talked about in the previous Q&A session. Thank you.
Thank you very much. Robert, maybe you can finish off, Marcus, with a final question.
There's one crucial question, I guess, which we all have to ask ourselves. What future innovation would we need to integrate digital prompts in our clinical routine as physicians? Maria, what would you think?
It's a huge question. We are aware that we need, for sure, to integrate the patient perspective to complement our classical tools. We need, for sure, to converge, in my view, on a few instruments, because we have a jungle of instruments that are continuously changed and continuously produced. So I think one of the tasks of this project is converge on a few instruments, and if they are already validated, or validate these instruments and implement in patient care. So I think that we have to really have the courage to select a few, those that appear to be most relevant to the patient, and try to go on, validate, and implement in our care.
I think for digital tools, the main problem, I think, is in the visualization to patients. So I think we need a uniform way of displaying the data back to patients so they can see it. They'll be invested in the technology, and I think adherence rates will then be a lot higher. They really want to see all this information, and it's withheld from them because just the clinicians are looking at it. And even the clinicians don't understand it.
And to slightly contest the point, we did a qualitative sub-study in consonance where we asked our patients what would they like to see to have higher adherence overall. And for some of the patients, it's very discouraging, especially for progressive MS patients, to see that they continue to decline. And over time, it's just getting worse and worse and worse. Some patients are very motivated by it because they think that they can continue and somehow overcome it and improve. But over time, it can have very detrimental effects to their psyche.